When we started CCOs, we went into communities, and it was pretty clear that our healthcare system throughout the state was pretty disjointed.
The idea was, how do you take all these disaggregated parts of the healthcare system and have them work in concert to the benefit of each individual member, and hopefully to the benefit of the whole population? Then what savings and what efficiencies can you find for the system?
And it isn't just public health and hospitals and behavioral health, but it's also community organizations that deliver social services. So organizations that are involved with food and housing.
As healthcare providers, we need to address whatever it is the patient comes into the clinic for. So if they're hungry, we need to provide them with food. And that's what CCOs allow us to do.
So part of the CCO model was allowing CCOs the flexibility to devote resources to social determinants of health, to community organizations, and to, quite frankly, focusing on reducing disparities.
We, as a CCO, outreach to members with social determinants of health risks or special healthcare needs, and we'll reach out to them and find out what they need and help them get connected to not just one or two, but any agency that they might need to connect with.
Local control and flexibility are important because ultimately this is about improving the health of both individuals and of a community. And to be able to do that means that organizations need to be responsive to a community voice. And what the CCO model does is it allows the flexibility for CCOs and for communities to respond in ways that make sense in their community.
Having the opportunity for members to speak to what's going on in Lane County, what the specific challenges are in Lane County, is critical because they're different than what's going on in Deschutes County or what might be going on in Multnomah County.
So what you'll find is that a lot of health centers are now partnering up with community organizations that do different things, partnering up with a lot of the folks that experience houselessness, partnering up with organizations that provide housing.
Over the last couple of years, we've experienced a lot of challenges: COVID, wildfires, heat, ice, and the CCO model allows us to locally be flexible and adapt to those challenges that come our way in a really just very fast turnaround. Even just recently with the unprecedented heat waves and the huge goal of preventing deaths like we experienced in 2021 due to heat. As soon as the heat advisory was proclaimed for Lane County and for our other CCO regions that Pacific Source does business in, we immediately got the lists, started building a climate dashboard, working through the lists of members that would be at highest risk for heat-related bad outcome, and started working through that list and outreaching to all these members just immediately. This was maybe 12 hours from the time we identified that there was a heat advisory we needed to provide outreach to when we were calling members on the phone, and just pivoted everything that our member support specialists were doing for a few days to kind of all hands on deck. Let's reach out to these members. Let's see who is at risk. Let's direct them to cooling centers near them, or find out what we can do to help, whether it's purchasing a portable air conditioning unit for their apartment, or helping them with getting transportation to somewhere where they can be cool. It was just an immediate all hands on deck, and it was beautiful.
The coordinated care model within the state represents systemic change.
Lots of people around the country are really interested in our model and are seeking in their own ways to replicate it.
And there's a huge opportunity here to address disparities, both in the outcomes for certain populations, both in how these populations are treated within the traditional medical model, and with how the community responds and how the community can be used to integrate these populations into an environment that improves the whole health of an individual.
CCOs allow us to have these patient advocates, right? Allow us to have these peer support groups that can speak to their lived experience. I think lived experience is incredible, is a powerful teacher. And when you can have folks who have walked down that path, folks who have seen that, they speak a different language than those that haven't.
So the value and the change to the coordinated care model was now several. There was an organization, an entity accountable for the health of a population. It really brought in a community voice that hadn't been there. Individuals now had their care coordinated by one organization, not by 3 or 4. There was a real focus on quality and on quality improvement.
A good example is, actually, the best way to tell the story is, I had a patient who came in who was complaining of poor sleep. The patient's mental health prescriber had reached out to me to say, hey, this patient has been declining the last 3-4 months, and we are trying to adjust the medications. One of the things that this patient talked about is that they were not sleeping well. This patient had gotten into an apartment that was provided for by this FQHC through their housing department. And unfortunately, they did not have furniture. This individual did not have furniture. And so they were laying down in the living room without a bed. And so that was interrupting their sleep. They were not getting good quality sleep. Over 3, 4, 5 weeks, which then turned out to be 3-4 months, poor sleep can lead to decompensation from a mental standpoint. Yes, it's very easy to write a prescription for Ambien for them to sleep well, to get more sleep. But what they actually need is furniture, a bed in their apartment, so that they can get a good night's sleep. So I reached out to the care coordinator to say, hey, can you please see if this individual who's on OHP can get furniture as part of what OHP members can get. And sure enough, we were able to get furniture for this individual. This is the whole power of care coordinators, right? Who are there to make sure that individuals get what they need. And also talking about care coordination, right? Able to get this information from the psychiatrist who's concerned about the patient's mental health, to compensating, to transmitting it to me to say, hey, this is something that the psychiatrist wants you to take a look at. And then being able to transmit that back to the psychiatrist.
We had a family that had really hit rough times, and it was a dad with 3 little girls, and they all had chronic conditions. They're all pretty complex little ones, and we got them a pass to the pool, and they were able to go to the pool, and he wrote us the most beautiful letter about how he was taking his girls to the pool 3 days a week. It had just really changed their lives. They were able to be more mobile, their mobility improved by having that physical activity, and just their emotional health improved too by having something to do together as a family that was healthy.
So as we look back at the last 10 years and look forward at the future, we've made tremendous strides in creating new organizations and improving community health and keeping in check the rapid growth of astronomical healthcare costs. And I think we need to double down on that as we move into the future, strengthen that community voice, because by doing so, I think we'll strengthen our CCOs.
Being in this position where I can help shape how we deliver care and how we recognize each other as individuals who respond to that humanity in each and every person, that's exciting to me. That's medicine.